Just so good morning and welcome to this follow-up session on community health promotion and building behavior change and healthy behaviors in communities. This particular session, which is hosted by Transform International, is about community health evangelism. And I'm going to pass things over to Jim McGill to introduce our speaker, Dr. Bernie Bledsoe.
I'll pass it over to Bernie and let him introduce himself.
Well, that's fine too, as you wish.
What he has done, because I was asking all the health people around here, how could we start doing some WASH and healthcare facility work? And I was getting blanks from everybody until I started talking with Bernie, and immediately he linked up to experience he already had, so I'll let him describe that.
Okay.
Thank you so much, Jim. Thank you, Nancy. First of all, I want to introduce myself. I'm Bernie Bledsoe. I'm an American family physician. I have been working overseas in French-speaking West Africa for the past 15 years. I have worked in many different environments, in clinics, village clinics, mobile clinics. I have worked in HIV care and treatment centers. We have been in community health. I have been in epidemic response. Currently, I'm working as a part-time physician for the U.S. Embassy here in Nigeria as well as my full-time job, which is community health and disease prevention education in communities here in Western Nigeria. So community health evangelism is something that's very near and dear to my heart. It's something that is a really impressive approach. When I was preparing to come overseas back in 2001, it was recommended that I go through this training. Let me put it this way, it was strongly recommended that I do this by higher ups, and so I was trying to find the time and just couldn't find it. And so when I finally went to the training, I was just absolutely blown away with their approach, the way that they understood community, the way that they understood individuals, and the results that were coming from this approach. So it was transformational for me in the way that I continued to look at the work that I was doing overseas. So it's a great joy to be able to share this with you. So first I want to just kind of start by describing a little bit about history. So CHE has a long history in development. CHE is a development program. We completely recognize that relief is very important. There are situations where people need vital assistance. There's catastrophes, national disaster, war. There's several different situations where that's necessary. But CHE doesn't really work a lot in the relief area, but very much in the development, identifying capacity, identifying resources, and community mobilization so that individual communities, whoever they are, can start to identify the problems, identify the resources, and see how they can bring transformation and change into their community. It starts always very small scale, but it gets pretty big pretty fast. So there are some pioneer programs. First of all, it was started in Uganda by a gentleman called Stan Rowland, and he was working in villages establishing these CHE programs. Every one of these programs demonstrated a lot of improvement in physical indicators, as well as in this context, spiritual indicators as well. And there was a lot of multiplication going on, which was something that was a little bit new and different in amongst the approaches that were currently going on at that time. Later on in the late 90s in the Congo, during the Civil War, there were a lot of Western presence, a lot of expatriates left the country. Not only did the CHE programs in the country continue to provide education and training to communities, but several of them multiplied during that time. And so it was that was one of the hallmark moments where people started to really understand that CHE had this incredible capacity or incredible ability to make an impact in communities. And the most important and the final indicator of a CHE project is multiplication. Does the information that we're teaching and sharing and communicating with the community, is it important? Is it important enough to learn? Is it important enough to share with your neighbors? Is it important enough to motivate you to go to other communities and teach them as well? So those are some of the things that we really look for in the CHE program. And there have been, I have seen a lot of CHE programs that do really, really well. I've seen others that struggle, but with time, they all come to this point where they start multiplying. And so it's really impressive to see. First of all, CHE is something that is not just...
Bernie? Sorry, the sound is breaking up a little bit. I don't know that there's anything we can do about it because it may just be the internet connection to you, but I just thought I'd flag that.
Okay.
It might be possible, Bernie, to be closer to the microphone. That might improve.
Okay.
It's just so interesting. I don't want to miss anything, so keep talking and we'll tell you.
No, it's no problem. No, yeah. So I will also try to speak a little bit more slowly so that if there are gaps, they fall in the gaps. So,
Thank you.
CHE is a program that is known worldwide, so it's not just in Nepal or just in Africa. And you see this map here. This is from the Global CHE Network, where several different partners, people doing CHE on the ground, all come together to share experiences, lessons, encouragement. This is from the website, and we're a part of that network. They're the folks that provided us training in the beginning, and we continue to work with them. And so it's a great network to get involved with and to get to know if you're interested more in community health evangelism. Okay, there we go. So, to really describe what CHE is, I just want to take each one of the elements and just define it so that we're talking about the same thing. The first element, obviously, is community. So in the trainings that we do, we define community as this, a group of people who are near to one another, and they share similar problems and interests, values and resources as well. The last two things are really important in my experience with CHE to note. First of all, community is growing. We have seen communities where we're working actually shrink and dissolve. We have seen others change from a situation where there's several problems, almost a disastrous situation, into transformed communities where their focus is more how can we help our neighbor versus how can we help ourselves. So we've seen a lot of this, and so it's just important to remember that communities can grow and change. When we talk about community health evangelism, we're talking about things that could be something as big as an entire village. It could be something as small as a women's group of five women, a youth association. We work with unions. I worked in a prison where we did community health evangelism as all the prisoners realized that they had similar problems and interests. And even though they didn't have a lot of resources, they did have some. And so we got to see prisoners exchanging resources and helping to improve their environment, as well as their reintegration into society. Where we did a lot of work was we used CHE as an approach in our communities of people living and affected with HIV and AIDS. These communities, they were of many different ethnic groups in a country where ethnicity was very important. And all of a sudden, these men and women and children were all found to be together with a similar problem and similar interests. And to watch as this community developed, as HIV became something that was more spoken about, and people were becoming more educated on what it was, and as people were starting treatment, and it was no longer this stigmatized thing, but it was, virals, and now I want to continue with my family, and I would like to get married, and I would like to have children. We use community health evangelism as an approach to create community amongst this subgroup of the population, as well as to equip them to help one another, to encourage one another, because so much of what they were having to do was still very much secret. So all of that is to say community can be anywhere. The second aspect is health. And this is the thing that I was expecting when I did the training the first time, that health would be medicine. And we would be teaching village health workers how to, give Fansidar for malaria or amoxicillin for an ear infection. And then when I started learning more about what health in this context was, I have to say that my mind was opened to things that I had never considered health of an individual. So there's nothing more frustrating as a physician to see, a patient. You diagnose them correctly. You prescribe a treatment that they are able to afford and they can pay for. And then it doesn't go well because there's a cultural stigma attached to it, or because in their family there's a broken relationship, or a malnourished child that can't get the food it needs because a father is unemployed, or because someone is having a problem with substance abuse. So all of these factors play into what is good health, and that's what we take into consideration when we're talking about health at a community level. So obviously, CHE is holistic in its definition of what health is. It's not just physical or medical, but it's everything. And we focus a lot on the restoration of harmony with these four factors: harmony with oneself, with nature, which means their environment all around, which is where WASH comes in quite a bit, but it plays into many different areas. Harmony with others, as we try to bring reconciliation and restoration into relationships within the community. And from our perspective, and this is our faith perspective, and with God. And so what we find is a lot of communities are very open to seeing the problems with these four areas and trying to reestablish them. So it's very important to focus on these things in our development programs, or in my experience. The last thing is we focus a lot on prevention and promotion. So prevention of illness and promotion of good health, which again is where things like WASH, but even things like literacy plays into that. Nutrition plays into that, obviously vaccination. But we don't spend a lot of time on treatment, and the treatment training that we do provide is typically stuff that people can do at home, like how to make your own ORS and how to do certain things or certain treatments at home. But it's really focusing on keeping people in good health versus responding to a health crisis after the fact. And the last thing is evangelism. In certain contexts, we don't use this word, we just use education. It's not a bait and switch situation, but I just want to make it clear from our background and our perspective, we are here because of our faith. But not everyone is, and that's fine. This word is a stumbling block for many people. And so they ask questions, if I'm not a Christian, can I use these ideas and approaches? And the answer is absolutely. The thing that I want to just bring up is that in the context where we work, and in many contexts around the world, whether you believe in spirituality or not, or where spirituality is, the people that you're working with do believe in spirituality. They do have a spiritual framework with which so much of their life is filtered through. So that's why I say that, yes, everybody can use these, because even if the person is not necessarily a Christian, the people that they're working with do sometimes have that faith background, or they have a different faith background. So it's important to at least recognize this on the community level and allow people to use that as a source of strength for them. The community. So
Bernie, this is Stu. I have a question about the evangelism.
Yeah.
If someone is not Christian or of this particular faith, I'm wondering what would be the equivalent energy that they would bring to the community? Is it social well-being? Is it self or community improvement? What would be their equivalent?
That's a great question, and it is a lot of people approach these communities as good deeds, humanitarian efforts, and so the context we're currently in right now, we're in a country that is 99.8% Muslim, and so everybody, but about 1% of the people that we work with are not of our faith, if that makes sense. And so when we come into a community, because of the way we act and because of what we do, our faith is pretty much known from the start. The vast majority of actors in the program are not Christian, and I would honestly say they don't have any intention of becoming. But we see that as we go through the program, people do, they appreciate the positivity, they appreciate the hope that we encourage as they talk about the problems and as they talk about the resources that they have, which the vast majority of the communities I work with, they all believe come from a deity or another. So I don't know if that answered your question, but hopefully there are ways it goes. You can approach these communities, not necessarily from a religious standpoint, but still get some of that impact. The other aspect I would say is that, I'm sorry, I lost my thought, but yeah, I'll come back to you. So those are the things that I would just mention.
Maybe if I could, because you were talking that there's been so many breakoffs from Che, and they're not all Christian breakoffs. They're humanitarian breakoffs. I think if you could talk about that a little bit, that might be addressing what he's asking.
Yeah, we there have been several people who have used this approach, and they're completely laic secular organizations that don't have any desire to incorporate any faith-based component to it. And they do see transformation, but again, it always comes back to the belief of the people in the community versus the people who are bringing the education and training or the education or training. The other component I did want to mention is the transformation aspect. So a lot of times we end up working with people of similar faith as we are, and that common bond does help establish trust. That common bond does help establish communication. So we can talk about the same things with similar values, if that makes sense. And so communication is facilitated. But like I said, the lessons, and this continues on the PowerPoint, the lessons that are developed through CHE are integrated physical, spiritual things. And so it would be hard to take a CHE lesson from the database that they have and to eliminate a part of it. But I would discourage people from doing that just because, like I said, the audience is normally people who are wanting to hear that aspect. And if it's absent, they will put it back in, if that makes sense. So. Was there another aspect of that question that you wanted me to develop?
No, that's fine. Thanks.
Thank you, sir. And there is no religious program. You don't have to do it. But I would say that the impact on the transformation, it goes a lot easier when people are of the same faith, or at least common spirituality. So talking about the approach now. So those were the elements. Community can be big or small. Health in a very holistic sense. And evangelism in the sense of bringing, again, holism to the way we're approaching community problems. So the approach, first of all, there's numerous models, and people have used it all over the world. There's urban, CHE, church-based, family-based, working with different subpopulations and people with that, or working with children. So this has been adapted in many different contexts. And so there's a lot, and all of this stuff is on the Global Chain Network. So you can get more information on that from there. But what is really interesting is all of the approaches, whether you're working with a subgroup of the population or the entire population, it all leads back to a community-based approach. Because as the information is getting multiplied in either the church or the family or the subpopulation or the support group, it provides such an impact that people start sharing it with their neighbors and their friends, and it eventually gets to a point where people start coming together to work on community-based problems. I'm going to be specifically talking about WASH CHE today because that's what we're currently involved in Niger. Prior to this initiative, I've done a lot of work with youth groups, women's groups, churches, as well as communities here in Niger. But this specific subsection where we're talking about water, sanitation, and hygiene in the context of community development is something that is really important in our context here. It's a huge problem, as well as something that I'm really excited to see how it's going to develop. So we're using a family-based approach to address WASH and hygiene. So WASH, I'm sorry. So this is basically the structure or the organogram for how community health evangelism works. So there's a training team, and these are typically people who are outside of the community. Those trainers can then train people within the community, or they can train somebody outside of the community and help introduce that person into the community. I know I'm saying community a lot, but I think I'm hopefully I'm making sense here. But the trainers are always outside of the community. Every other actor is within the community. So we'll be going through this in a detailed way, but I just want to kind of give you the big picture of how we're working here. So first of all, the trainers train a WASH community health educator, which unfortunately we also call it CHE, lowercase. So a community health educator, and we probably a month and a half.
Should still be good.
Yeah, our connection is getting a little bit weak. So we'll be spending about a month and a half training WASH community health educators to understand different aspects of WASH. In our context here, we're associating the WASH CHE with a healthcare facility. Back in last year, and back in 2018, there was a huge cholera epidemic that occurred in the central part of Niger. The government and NGOs rallied very quickly to try to get a hold or try to get control of the epidemic. And they did a pretty good job. The problem is that the healthcare facilities were often the nucleus of contamination and propagation throughout the community. So as people were getting ill, they were coming to the healthcare facility. There was not adequate sanitation and hygiene in the healthcare facility. And as people were visiting, as people were coming to assist the patient or people from the healthcare facility, they were getting ill as well. We saw this as well in the Ebola epidemic that occurred in West Africa, where healthcare facilities became a nucleus, or became the nuclei for contamination within the community. So the training that we, the training team, are going to provide for our WASH community health educator is multifaceted. First of all, we're going to teach them a lot about community mobilization. How do you mobilize people together? How do you restore or broken relationships with the community? How do you get people working together on common problems? We'll be also training them in hygiene, both personal hygiene, food hygiene, as well as community hygiene. What are some sanitation issues? We'll be training them in water and waste management. We're also, we've gotten access to the World Health Organization standards for biomedical waste treatment and disposal. And we're currently translating that information and putting it into a training module, because our specific WASHs need a platform with which they can speak into the community. Sometimes this can be somebody who just lives in the community, but we know these WASHs and we know the communities where they're going to be living. and they need this platform. So they're actually going to be working as volunteers in the healthcare facility, being expert in biomedical waste treatment and disposal, and doing it according to the World Health Organization standards. We're also going to be training them in nutrition and disease prevention, multiple types of disease prevention. So that's kind of where it starts. The training team building a strong relationship and equipping the WASH-J. If this were a situation where we're not putting the person into the community, but we're working with people who are already existing in the community, we would do the exact same training. We would do the exact same training, but we would do it on a much larger scale. And we would be doing this training to representatives of women's groups or kids or youth or adults. And so we would just be doing it on a much larger scale. From there, after we feel that the community health educators really understand the content, they have simulated back to us the way that they're going to teach with participatory learning activities. We will then facilitate their entry into the community. Again, everything has to happen on the community level, so this can't be somebody who's coming and going. It actually has to be somebody who is a stakeholder in the community. In order to facilitate this entrance, what it requires is basically lots of meetings, meeting with community leadership, village chiefs, leaders, nurses and doctors at the healthcare facility, the local school, anybody who has a decision-making role in the community. We would want to meet with them, introduce who our WASH-J is, and kind of the role that they're there, and to get buy-in. We use a lot of participatory learning activities. Many people know what these are. The river crossing, role play, the problem and solution tree, trend analyses, these type of activities that start bringing the community to see the importance of mobilization and holistic development.
Can I ask a quick question?
Sure.
So, and if you said this and I missed it, I'm sorry, the sound is coming and going still, but how do you pick the WASH-J, and do you consult with the natural leaders or the traditional leaders, or have the community help pick that person, or do you have some kind of criteria? And that's question one. And secondly, how are they incentivized to get involved with this and to continue to be involved with it?
Those are great questions. For the incentive part, I'm going to tell you that later on.
Okay.
But for the choice, how we do that, like I said, there's two ways. We're doing this one for WASH-J because we already have a network of people who are in these communities, and we're pulling that person out to train them and then allowing them to go back. So for us in this context, we already know who they are. And so that makes it a little bit easier. They're people who are already accepted in the community, even though they don't necessarily come from that village. They already have a great reputation in that community. But on a general scale for community health evangelism in all aspects, it is always the community that chooses the individual. So there's never a situation where we're here based in the capital in Niamey, where we would find 5 to 10 young people, train them, and send them randomly to villages where they don't already have a connection. I know a lot of programs do that, and it brings a lot of great results. But in the chain model, that's not the way it's approached. So I apologize. It's a little bit confusing because we're working in a specific context of WASH-J. But whereas there are boxes outside and inside the community, we're working only with people who are already capable. If that makes sense.
Yeah, it does. Thanks.
Okay. So this is the part where a lot of people say, I don't want to do anything. I don't want to have anything to do with J. It takes time. It takes time to get that community ownership. And so I'm putting 3 to 6 months. Sometimes it really is 3 months. Sometimes it can go longer to even a year or two. And unfortunately, sometimes the community just is not at a position where they're able to work together yet. It doesn't mean they won't be in the future, but we have had to occasionally just say this community isn't ready for this type of approach. We stay in relationship with them. There's nothing pejorative. It's not like we say you didn't meet our criteria or anything. But what we do is we just continue to work on the participatory activities and help to try to bring reconciliation in the community. But the reality is it takes time. This aspect of getting the community ownership is the slowest part of it, but it's the foundation that everything else is built upon, including when we talk about incentives later on. So community ownership, super important. The next step, especially with WashCHE, is to get engagement with the healthcare facility. And so our WashCHEs, after they receive the training, and like I said, in the community engagement component of this, we have already talked to the medical staff of the healthcare facility. We talked to the COGES, that's the French word for basically the management committee of the healthcare facility. And we have talked with them, and if we have their buy-in and ownership, we will then place this WashCHE as a volunteer in the healthcare facility. They will, in our specific system, they will be working basically a half day. They will be there during patient care, and they will be there to assist the healthcare team with all of their wash and biomedical needs. This will be basically making sure that there are functioning hand washing stations that are up and running. Soap is available. Latrines in the healthcare facility are repaired and maintained. And also how to bury or incinerate in an appropriate way biomedical waste. The appropriate management of biomedical waste in a resource-poor setting is quite a bit of a challenge, but the World Health Organization does have some guidance on that, which are best practices for resource-poor settings, if that makes sense. And that's what we'll be training our WashCHEs in. We're also a member of the healthcare team, and the fact that they will play a role as doctors or nurses identify people who have wash-related illnesses. The WashCHE will also, with permission of the family, do home visits with these patients, where they can do home assessment, encouraging parents on hygiene and sanitation in their home environment, or maybe even doing it with a group of people, that type of thing. It's a situation where we have seen this happen in the past, where we have put community health educators in healthcare facilities, and the medical team really appreciates having that community relay or community liaison, so that there can be follow-up in the community with children or adults who are having wash or nutrition-related illnesses, so that they're not just overwhelming the healthcare facility with repetitive illness, that they can actually learn preventive strategies and put them into practice. It's worked quite a bit in the past, and so we anticipate with WASH in our healthcare facilities here, it will work as well. And then the last thing is we want to continue to build a relationship and motivate the community leadership. So the WashCHE, as they're volunteering at the healthcare facility and dealing with those issues, will also be a resource for the community on all WASH-related items. Like I said, multiplication is the goal. So as the WashCHE is working in the healthcare facility, is reaching out to the community through illnesses and disease prevention and education, they will also be touching the community leadership on a regular basis, just trying to encourage the community to come together to do very simple things like cleaning markets out or handling stagnant water within their community during rainy season. Or there's many different strategies, but we have seen these community health educators do incredible things with very little resources.
I'm really intrigued by this, Bernie, because clearly the person who's the WashCHE has to have some confidence and has to be viewed with some kind of status to be able to have that kind of impact, I would think.
Absolutely. And it's all about having the right person. And
yeah.
so
yeah.
as community chooses that person, we get to mentor that person. And so, like I said, we're talking about a month and a half of training, but that's going to be, a lot of times these are volunteers or not paid individuals. So we have to go along their schedules. So it could be as long as, a year to get them fully up to speed. So in our program, we're going to be teaching them the WASH aspects first, like hygiene, sanitation, how to do community mobilization. The biomedical waste component is very specific and very technical. And to be quite honest, can be very dangerous if the person doesn't know what they're doing. So that's kind of like the last aspect of what we're going to be training, so that we can have this great relationship and know if the person is going to be able to handle that level of training. If they can't get to that level, that's perfectly fine. They can still have a community impact, but we would really like to see them get to that place. But sometimes it takes a lot of time. But again, you're exactly right. It has to be the right person. We often talk in CHE about a champion or a person of peace. Basically, this is that special person. And in my experience over the past 15 years here doing this, we always find one. It's rare. In fact, I can't think of an example where we don't find that really motivated individual within the community. So I don't know why it happens, but it always does. We always find it. So.
Bernie, this is Stu, and I have a more personal question. Why did you sort of leave the narrow focus of your medical profession to move into this, or do you do both at the same time? And why has it been satisfying for you?
That's a great question. I wanted to make sure I didn't overwhelm you with personal stories, but since you asked them, I'll tell you. So my first long-term foray in Africa was in a pediatric HIV care and treatment center in Eastern Ivory Coast. At that time, Ivory Coast was the country that had the highest prevalence of HIV in French-speaking West Africa. It wasn't as high as the rest of Africa, but it was still a center. So there was a lot of work and a lot of initiatives being done. So I was working in a very simple clinic in this small town, and there were NGOs coming in, and there was PEPFAR funding coming in, trying to find and identify individuals who were HIV positive and to get them on treatment. And there was not a lot of success happening. And someone had asked PEPFAR to figure out why they were treating all these pregnant women who were HIV positive, but none of their kids were getting followed up on. So somebody said, hey, if you want to see the kids, you have to go to this missionary clinic that's around the corner. And so PEPFAR came knocking at our door and realized that we were taking care of the vast majority of children in the community. And so we started working with them on developing HIV care and treatment. I told my staff at that time, I said, you guys, we're going to have maybe about 30 or 40 kids over this next year, and we'll support them and we'll help them and we'll get them on treatment, and we'll be able to help provide a lot of support for this fight for people living with HIV and AIDS. And we began the training, and we started testing the patients, volunteers coming to our clinic. And within the first 2 weeks, we were already at 30. Within the first 3 months, we were at 100 patients. And over the next year, we were over 2,500. And as I was treating families, not just adults or children or pregnant women, but family units for HIV and AIDS, I was realizing that so much of what I was doing was honestly not helping, because I was identifying their CD4 count. I was establishing what they needed. I was giving them free Bactrim. I was giving them free antiretrovirals. And then they would go home and hide it, or have to, once a week take an antiretroviral when the husband wasn't there, or whatever, or they were sneaking into their child's food because they didn't want to tell the child that they had HIV. These type of things. There was just so many social and community factors that were playing into the medical treatment of individuals affected by HIV. And then I was seeing the impact on school and education and work, and all of that is to say, and everybody knows these stories, so I'm not producing anything new, but my point is that when we left Ivory Coast, we were in a situation where the CHE program was completely being run by Ivorian leadership. They were doing an incredible job. It was multiplying, and we were looking for where was the next step for our family. And that's when we looked at Niger, and why we came to Niger, because it seemed to be a good fit for our family, and there was incredible need here. So when I got to make my own job description, new country, new place, nothing was built here. When I got to make my new job description, I was like, you know what? I want to deal with the root factors of these diseases, not necessarily just treating basically the consequences of these root factors. So that's why I do still provide a lot of care for people here, volunteer my time in different clinics, and I also work with US Embassy treating the diplomatic community as well. But my full-time job and my passion is being able to identify some of these root problems and help communities find them, so that we're not constantly dealing with epidemic after epidemic, but we're actually seeing communities grow and flourish. So,
Thanks for sharing that.
Yeah, wow.
long story, like I said, but no, it's super encouraging. So, okay, sustainability, and this is always the big question. And I'm going to tell you what we do, and I know a lot of people are going to be like, Billy, it really works that easily, and the answer is yes. For our WASH CHE program, during the training, we are going to equip these WASH community health educators in their own cottage industry. And then we're going to allow them to continue to develop their own income base with the community. So we will be teaching them how to do soap making. We will be teaching them how to build and construct improved cooking stoves that are more energy and environmentally efficient. As we develop or find programs to dig boreholes or dig wells or build incinerators, these WASH CHEs will use those opportunities as income generating activity to support their volunteer work in the healthcare facility. And I know theoretically that sounds really good, but in my experience with CHE, there was a question before we even came on asking, what is the cost? What is the cost of running a CHE program? And in my experience in West Africa, and this is a hard place in the world to do a lot of development from time to time, because there's just a lot of relief activities going on. And so I can't really give you a number, because the only thing that costs for us is the training. The volunteers, both in Cote d'Ivoire as well as in Ghana and in Niger that I have worked with, I have never paid any of them. And they are people of a strong motivation and faith. A lot of times they already have a career, and so we often look for people who are already, they already have a career in their community, and so we train them, and this becomes a part of their life. But in this situation, we're actually not going to be paying anyone to do these. They will be truly volunteering of their time. Now, the advantage of that is these principles are being lived out for real. And that gives the community a much clearer understanding of the training and the words that are coming out of the educator's mouth, if that makes sense. I've seen a lot of situations where someone is very intelligent and they've mastered all of the material, but they haven't applied it to their own life. And so when they go into a community, people notice, and I apologize for the word, the hypocrisy, and the fact that the community educator is saying one thing, but doing something completely different in their own life. And so one of the things that we do in our training is our first target population is the WashJ themselves. So making sure that that individual is applying everything that they've learned into their family, into their home, into the way they live. And then from there, their message has a lot more impact. But our program in Ivory Coast, for example, I was not the only person training, but we started with a training team of 7 individuals. I'm still in contact with all of the 7 individuals, and none of them are salaried. But they have created a national association for CHE, and they have CHE plants in over 1/2 of the country. And it's all still to this day being done by volunteers. I mean, when we're talking about boreholes and wells and those type of things, that requires external resources. It just does. It requires people with the technical equipment. Even if the community can raise the funds, it still requires outside resources, and we're not opposed to that. But the sustainability for us is making sure that the actors within our CHE program actually have a way to sustain their own livelihood. So they either already have a career and they're passionate about seeing community transformation, or we help them with cottage industry training and allow them to make their living while they're educating in the community.
Ernie, I've got a question about the 4 items underneath the word sustainability. Are those purchased by the organization and delivered to a CHE? Are they purchased over time? How are they acquired, and who gets them? Just the CHE or everybody in the community?
The CHE, we will equip them, like as we're doing the training. Unfortunately, soap making, it takes a lot of practice to get it right.
Right.
That's an example. But so we will provide that material for them to practice on, and they will get a kit. I mean, here in Niger, that's a $6 investment. So it's 3,000 CFA. And for example, same thing for the improved cook stoves, as they are practicing building it for, during the training, they will get to go home with one. Things like incinerators, selling water from boreholes and stuff like that. That is stuff that will definitely have to come from outside of the community. But and why I chose these 4 is because these are important things in the communities that we're going to. They could be other things. They could be, we have seen microloan programs started where, and everybody's heard of these things where somebody gets a revolving loan, they pay it back. And so that's sometimes how we fund our CHEs, by putting our CHEs together in a revolving loan program where they put their own money in and then they loan their own money out to one another to get everyone started in the program. Again, this takes a lot of time. It takes a lot of time. But we don't on a routine. So the WashJ will then, with whatever they have or whatever knowledge they have, they will then teach people in the community. And then, like for the example, the improved cook stoves, they will sell those in order to make a living. They will sell soap, hopefully to the healthcare facility who's using it on a regular basis. Even within the community, things like kitchen gardens and stuff like that, that's just for their own personal usage, which will just decrease their expenses. That makes sense. The other aspect, which was my last point, projects start with local resources. That's the other reason why this is so sustainable, is because the vast majority of projects that the community takes on are projects that they can do with their own resources. So there's before we jump to, providing electricity for a village or, building incinerators or that type of stuff, we have a history of the community identifying small projects, using their own resources to improve their livelihood. And then that gives them the motivation to continue to do bigger and bigger things. In my experience in Ivory Coast and in Niger, whenever these things like really are at full speed moving forward, I would say about 75% of the projects are all done locally with their own resources. We had one community, if I can tell this story real quick. We had one community in Niger these were refugees basically. So there was a huge flood in 2012, and these people lost their home. So they started rebuilding their homes in this vacant area that they were given by the government. And so there was no running water, there was no electricity, there was not a lot of infrastructure. In order for them to obtain water, they had to walk quite far, and they had to push the water up the hill. And so there were people, which we call it here, who were filling up bidons of water and taking them up to this community, but they were charging quite a substantial amount for this community to have water. And so one of the things that they did was they decided to just communicate. And so they did about all of these are volunteers. They went from house to house, and they just taught the community about the importance of potable drinking water. And then from there, they had a meeting at the mosque on Friday saying, we need to get boreholes in our community. And so they signed a petition where all 500 of the homes and households in this community unanimously signed a document saying that they would support and even provide for any boreholes that were done in their community. And they submitted this to the national organization which handles water issues, especially in semi-urban areas. And so they submitted this, and the organization said, we have never had a community come together. We've had individuals say, I want one in my house, but we've never had a community come together to say that they were willing to work together to support their own community. So this organization provided all 5 of their boreholes for absolutely free. And that was done in 2014. And we're 5 years later, and they're still managing the water from those boreholes. And with the profits that they got from selling the water at a very reduced price in their community, they're now starting to build electrical poles so they can electrify their village. So.
Amazing, eh?
Yeah.
Yeah.
It's pretty impressive.
Yeah, it's great.
So, the other advantage of community health evangelism is multiplish this community-owned resource, and they're moving and bringing change to their community. It is very easy to integrate other things into the program. So if we start out with WASH, these can be agents of literacy, or agriculture, appropriate technology, health. There's a hospital here called Cure International, and they provide free cleft lip, cleft palate, and club foot repair. But they're having a hard time finding patients because patients in the interior of the country are not aware of the services that they provide. So once we establish this WASH program, we will also be training our WASH CHEs in how to identify club foot and cleft lip and cleft palate and club foot, so that they can start also helping these communities, benefit from free operations that are happening in the capital. So, and then the last thing is the Global Chain Network has a database of over 6,000 physical, spiritually integrated lessons on every topic you could even imagine. So that's also a resource for anyone who's doing community health evangelism. So monitoring. These were hard slides for me to kind of develop because we do monitoring. We do continue to stay in contact with communities, but so much of what happens is their own initiative. So the first level of monitoring are the people who own the program. So the committee and the community leaders. In our WASH CHE program, That's going to be the COGES. That's going to be the committee that runs the healthcare facility, as well as the community leaders, establishing what their objectives are and what they want to deal with on a community level. The COGES will also record all of the home visits, all of the education that the WashCHE is providing in the community as well. So that there are statistics both for the government as well as for anyone who wants to participate and help these communities. The training team, we still stay involved. There's still a reporting that goes on between the WashCHE and us. But as we've said a couple times, the ownership is at the community level. So their direct bosses are the people in the community. But we still play a role. And like I said, we left Ivory Coast in 2010, and I still get reports from our training teams there.
Are we out of time?
Getting close, but maybe finish up and.
Absolutely.
Yeah.
This
Okay. Is so interesting.
And we've already mentioned, again, the objectives and the goals are all established by local authorities. So the stakeholders are actually the community members. And so the vast majority of reporting is internal. Mm-hmm. And then we do train our WashCHEs to do baseline surveys and after action surveys. So if there is any community projects, they kind of do it before and after to get some information at least.
Yeah.
And so the last part here is just SWOT, a SWOT analysis of what CHE can do, and to be completely open with its strengths and weaknesses. So with a lot of community engagement and ownership, problems are identified by long-standing community members. So these are the things that everybody is engaged in and everybody's excited about seeing changed. Community resources, holistic approach, contextualize. We do this in local languages. We do it in many different ways. And then it's multiplication oriented. Some of the weaknesses, some of the things that we have found that we've had to address is sometimes you have this committee that doesn't know how to lead. And so sometimes you have to provide training to the local committee in actually how to run a project or how to supervise or how to do reporting and follow up. So. And then the reality is local resources, and no matter what context, even in the middle of the US where I'm from, some resources just require external assistance. So it's important to be aware that those things are there. Opportunities, people of all education levels can be involved in this. I would say over 60% of the people here in Niger that we work with are illiterate. So they do it by picture books, they do it by reading Arabic script in their local language sometimes. They do it by memorizing stories or memorizing the lessons, and then we simulate it a lot, and then they just keep sharing it. The concepts, because it's done at such an easy grassroots level, it's easy to share. The best thing is it just gives a little hope to communities. A lot of the communities we work with here in Niger, they're basically like, we can't. And it's really exciting to see it when they can. Threats. One of the biggest challenges we have, unfortunately, is well-meaning organizations providing relief to communities who already have a development structure. We've seen, really great communities in the process of the CHE program completely get derailed because there was a distribution of rice, or there was this, or there was that. And it's hard to put that sweat equity in when there's that hang up. Not to say that that's always bad. I'm just
no.
And so corruption of the content, sometimes if people really understand it, they can deform the message. And then insecurity. There was a doctor in Congo that was there for 30-some years and basically worked in this bush clinic. He always said, where there's insecurity, development is paralyzed. So it's just one of those situations. So if there's a lot of insecurity, it's going to be hard to get programs like this up and running.
Yeah.
So are there any questions?
Wow, that was really interesting. Can we just briefly, because we are past the hour, in fact, what I might do is stop the no, I won't stop the recording. I'll keep it going. I want to just dig a little bit deeper into the work with healthcare facilities, in part because, as Jim knows, we're working with the Desert Research Institute to develop a toolkit to improve sustainability of WashIN healthcare facilities. And so we've been digging into what the issues are in different communities. And of course, one of the big challenges is funding, that there always seems to be a shortfall in funding to buy soap, to buy, to buy chlorine if they have a chlorine dispenser, to whatever it may be. But I'm curious, from your experience with CHE, what have you seen as the roadblocks or the issues that need to be addressed to improve the sustainability of improvements of WashIN healthcare facilities?
That's a good question. From my perspective, I want to give a little bit of background, first of all. So in French-speaking West Africa, everything is very, very much in the public domain. Mm-hmm. And so healthcare professionals, doctors, on the whole, are not necessarily people from the community. So there is occasionally that exception that you'll get a doctor right out of medical school who becomes a civil servant and is sent to this rural location where they aren't necessarily from. They may or may not even speak the language of that area. And they're there to basically treat individuals. And so one of the challenges is when we go to these communities and we're seeing the people who are running the healthcare facilities, they don't have a community interest. It doesn't mean they're not conscious of it, and doesn't mean that they don't care. But for me, the way to get the sustainability is we have to get the local ownership. We have to get the local leaders to own, first of all, the healthcare facility, as well as to get assertive in the board of directors or the management committee, saying that's fine, but the resources that are being sent to this healthcare facility, we need to have a voice in how they're managed. Mm-hmm. And so that's the biggest thing. That's the biggest roadblock. Is you'll find somebody who's there who just arrived from the capital 3 months ago, and they'll say, okay, for this to work, I need an incinerator with every filter known to man. I need 5 boreholes around here, starting with my house. I need this, I need that, and you all need to provide it for the next 10 years. Mm-hmm. And that's just, as you know, it's not sustainable. But when we've seen communities own the healthcare facility, even though it's not theirs and they're not populating it with healthcare professionals, when they own it, and I don't mean to sound crass, but that person who comes to the village is at the mercy of the village, if that makes sense. Mm-hmm. And so as long as the leadership in the village are like, great, you're here to serve us, this is what we want, it works out very, very well. Because that person who is affected there doesn't want the whole village to be against them when there's only one bus once a week from that village to the city.
but it makes perfect sense. But I'm sure that you and Jim have talked about this, and I think what Jim and I have seen in some cases anyway is people in leadership roles in the community taking advantage of that leadership role to benefit themselves. Right. And one of my fellow WashE Club members, Neil Van Dyne, who works in Haiti, they were having about a 50% success rate in terms of sustainability of water systems in communities until they started using MWater and mapping everything and being able to gather all kinds of information related to the water system and present that to the community. So suddenly people were getting information and knowledge that was prompting them to make different decisions. It was harder for them to be self-serving when it was so clear what the situation actually was and what the needs were. And that's really stuck with me as we move forward in the projects that we're working on. So it strikes me that it's community ownership, but it's community ownership that includes certain kinds of factors.
There's a lot of communication and openness in what's happening. Absolutely.
Yeah.
I think one big difference Nancy, is the amount of time working within the community. Because oftentimes we just go into a community and talk to the village leaders, and they make the decisions, and we go ahead with whatever we do. What they say, these Che people are being chosen. They are not the leaders. The Che people are the champions or whoever that come out, and then working with that community for first year in training, and then staying with that community thereafter. So I know this is something that I have not done myself. I've always done the other, and do the development and then work on how to make it sustainable after the infrastructure is already in place. So,
but I've come to the place where I think you have to do it the other way around. You have to make it sustainable before you actually build the infrastructure.
Well, I mean, and this is, I think, going to be one of our challenges with the Wash Che is the health centers are there.
Yeah.
And they are being led by external people, and it is a foreign thing. So how do we get this ownership? I think that's a big thing. That's going to be the challenge for us.
Yeah, really big.
The other thing that I would like to add is sometimes you also have to walk.
Sorry.
Sometimes you have to walk away.
Yes, you do. I agree. Yep.
And a lot of times what I've seen is when we've had to walk away from a community, we find success in a neighboring community. That community is able to go back to the initial community and bring the changes through a different.
Yep. Yeah, I completely agree. Yep. Very interesting. So I don't know if there was a website listed in the presentation, but where can we get resources? Where can we learn more? If somebody's interested in trying this program out and wants to get trained or do some training, where do they go?
That's a great question. I can send you my email address, which I can respond to folks who are locally. Also, there's the Che Network. If you just Google Global CHE Network, you can find people who are working in countries near where you're working, and they can provide training. Awesome.
This has been really interesting, and I'm just so grateful for you taking the time, Bernie, and for Jim arranging it at your end. So thank you so much.
And the Global Che Network is very much a evangelism network. So I think what
you mean a religious network, or what do you mean when you say? I mean, you can have all kinds of evangelism, but I'm not sure what you mean by that.
It's very strongly faith-based.
Okay.
Faith-based and using Che in order for conversion.
Mm-hmm. Oh, I see. Okay. Yeah. Mm-hmm. Okay.
So you'll get more practical, I'd say, by talking directly to Bernie.
Okay. No, that's really helpful and good information. Awesome. Okay. Thanks so much, guys.
Thank you for this opportunity.
Okay. Have a good evening.
You too.
Bye.